and welcome to Cancer Close-Up here at WVU Cancer Institute in Morgantown, West Virginia. I'm Meghan Turner. I'm an otolaryngologist, head and neck surgeon at the WVU Cancer Institute in the Department of Otolaryngology, and I'm here with Dr. Kristy Ward, a gynecologic oncologic surgeon here at WVU Cancer Institute in Morgantown. And we're here to talk to you today about HPV-related cancers, how to protect yourself from head to toe. So I'm delighted to be here with Dr. Ward today.
Yes.
How are you?
I'm great. How are you?
I'm well. We're here to talk about one of our favorite topics.
That's
I presume
right.
It's your favorite topic.
I talk about it multiple times a day.
Yeah.
So HPV is the human papillomavirus. It is an incredibly common virus that pretty much anyone who has had a sexual encounter probably has had exposure to HPV. There are multiple different types, but fortunately only certain subtypes are the type that cause cancer.
Yeah, absolutely. When I talk to my patients about HPV and they ask me regularly, well, what is HPV? And we say, it's a virus that you get from human behavior. And, patients are sometimes a little bit afraid, I think, to talk about sex.
Exactly.
But
yeah.
that's why that's why it's called the human papillomavirus. It's human behavior.
Yeah, there's no shame in it. And like I said, pretty much everyone has it because it's just so common.
Yeah, I think I saw a statistic that 90% of people have been exposed by the time they're a freshman in college.
Correct.
Yeah.
Yes.
So it's the same in your world.
Yes, absolutely.
Yeah. No, there's no shame in it. Yeah.
Yeah. So there's no shame in HPV because everyone who is human is probably going to be exposed to HPV at some point in their life. But there are things we can do to protect ourselves from HPV and things we can do once we get HPV to protect ourselves from getting cancer.
Yes, absolutely. I think it's not talked about enough, actually. What can we do to protect everyone from HPV? And we didn't really know that we needed to protect ourselves from HPV from an oropharynx cancer standpoint until really about 2009, 2011, when the first studies started coming out showing that there actually was a causal relationship between getting the virus and having an oropharyngeal cancer. So we've only known since 2009. Our field is in its infancy and even understanding and treating this disease. We only have 10 years of really knowing what's the best way to treat this disease. But you guys have been battling this for so much longer.
We have. So we started really recording cervical cancer rates in the 70s, and near around that time was when Pap smears, which was created by Dr. Papanicolaou, became recommended for cervical cancer screening. Papanicolaou testing is one of the, if you look at epidemiology, remember all your stats textbook, it's kind of the ideal screening test, and that we could actually follow from the point that we started screening from cervical cancer and just watch it drop dramatically. And then we kind of had a lull probably in the 90s and 2000s, and then we started to realize that the reason that people were getting cervical cancer was the HPV virus. Now, as we continue to understand and explore more and more about the HPV virus, we realize that almost all cervical cancers are related to the HPV virus. And since almost all cancers are related to this virus, that means that we can protect and prevent cervical cancer. So cervical cancer now is a disease of a failure somewhere in the system. So either a failure of the patient to seek care or a failure of us as the medical community to go out and find these patients and teach them and do the screening and the preventative measures that we need to be able to take care of this.
That's so interesting, and that is not at all the case for oropharyngeal cancer. It's sort of the flip side. Unfortunately, we have no screening process. One might think, well, could there be an oral screening? And yes, well, dentists do oral cancer screenings, but they're mostly focused on the tongue. There's very little that tells them to go and, hey, go look at the tonsils and see if there's a lesion there or ulceration. But that's theoretically one way where we can improve as a medical community in doing this. So Currently, though, it hasn't really been shown to be effective in oropharynx cancer. And most patients, unfortunately, present first noticing they have a lump in their neck. That's the way I would say 90% of our patients present, or they've had incidental imaging with tonsillar enlargement, or their PCP notices asymmetrical tonsil enlargement. That's the rare 5 to 10% of patients. So a lot of times we get patients once they're what used to be stage 3. Now we know they have a better survival even if they have a lump in their neck. So they're thankfully stage 1 and stage 2.
So what should people look for since it's so hard you can't screen for pharyngeal cancer, what do they need to look for? Like, when do they need to seek the doctor? When do primary care and dentists need to send them to you?
So a neck mass that lasts more than 2 weeks really should be worked up by a provider, and antibiotics is often the first thing tried. But in my opinion, that's really just wasted time. If it's a neck mass over 2 centimeters, you should be advocating for a biopsy, an ultrasound guided FNA to know what's going on for sure. Certainly, there's no harm if your provider puts you on an antibiotic to see if it goes down. But a neck mass that lasts more than 2 to 3 weeks should be worked up, and it's not just a cold.
So what can we do if we don't have screening to catch it early? Can we prevent it from happening? So
we should be vaccinating all of our children, boys and girls. So being, like I said, we're behind the 8 ball, and knowing that tonsil cancer is caused by HPV, we're behind you guys. We did not get a FDA approval for use in preventing tonsil cancer until 2020.
Wow.
So we unfortunately are going to be seeing tonsil cancer into 2060, even if we are hitting the targeted vaccination rates. And, I believe those rates, you want herd immunity, you need to be up into 70, 80%. And we're only, unfortunately, in the 40s, I believe, in the United States, 40% vaccination rates. And it varies by state. I think our vaccination rate in West Virginia for boys is the worst in the nation.
Oh, my goodness.
We are number 50. Actually, we're 51 behind Puerto Rico. So Puerto Rico is even doing a better job than we are. So that's what I would say is vaccinate your boys and your girls. That's how we're going to get ahead of this disease. And unfortunately, I think we're going to continue to see tonsil cancer because of the lack of screening, well throughout my career.
Because that's one of the things is that when you think of HPV, you think of cervical cancer, because that was the first indication for the HPV vaccine. And it's fantastic. We should, I agree, vaccinate everyone starting at age 9, and the indication actually goes all the way up to 46. So the main indication is 9 to 27, with the recommendation really being between the ages of 11 and 12. So before you have sexual contact is the goal. But there is an indication for certain people up to the age of 46. So like us who are physicians who are exposed to HPV in our jobs, it's recommended that we are some of the people who get it. But honestly, like we talked about, humans doing human things, you want to be vaccinated if you haven't been vaccinated. And I feel like a big reason for us not uptaking the vaccine is just the stigma that comes with, this is a sexually transmitted thing.
Agreed.
But
sex is a human behavior, and we all do it. Otherwise, we wouldn't be here as a species. So protecting ourselves is super important. There's actually a study out of Johns Hopkins, looking at, how many sexual partners puts you at risk for the HPV. It's only 5.
Yeah.
This is not promiscuity. This is normal lifetime, contacts, right?
And when we talk about it's 1 in 5, that's just statistics. I mean, if you partner happens to be the one that has the high risk HPV, then your one partner is the one who can give you cervical or head and neck cancer or any of the other cancers that go along with HPV.
So for cervical cancers, which are the strains that are most likely causing cervical cancer?
In the United States, we worry the most about 16 and 18. So there are multiple different strains that are associated with cancer, but for cervical cancer, it's 16 and 18, and they actually are associated with 2 different cancers that One of them is screened for easily with pap smear. One of them is actually not screened for very easily. The vaccine current vaccine has 9 different strains in it, and some of those are high risk, and some of those are ones that cause like genital warts or other issues that can happen in the genital area. So we've talked about cervical cancer, but as far as things that also can happen down there, it can be cervical cancer, it can be cancer in the vagina, cancer on the vulva, and cancer on the anus. And this is men and women with anal cancer. So while penile cancer is less common, it can also end up with penile cancer. So HPV can affect any of these areas where you have that mucous membrane to skin junction, which is all of our, GI tract, sexual organs, and all of those things that we need to think about and protect.
Yeah, so that's so interesting because it's also 16 and 18 in the head and the neck, and 16 is by far the most common. I can think of only a handful of my patients who had some other strain, maybe 1 or 2 with 30, 31 and 33. So it's just very homogenous, it seems.
Yeah.
Yeah.
So I talked a little bit about pap testing before, which pap testing is just actually looking at the cells of the cervix. Many years ago, we actually added on HPV testing because we know that cervical cancer is caused by the HPV virus, and we know pretty reliable that the majority of them are caused by 16, 18, and a few other strains. We can now test for those strains of HPV. And so we are going closer and closer to actually even getting away from looking at cells and really just looking at the HPV virus that you're infected with. There's actually a big trial that's going throughout the nation, and we have just opened it here at WVU called the SHIP trial. And what it's looking at is self-collection of HPV for cervical cancer. And what that means is, especially here in Appalachia, where it may be hard to get it to the doctor, is it the same as if I, as your gynecologist, collect the HPV? Can you actually go and collect it yourself as the patient, and is it as effective? We think it is, and that's actually what the test is right now. So if you go in for a pap smear and they ask you, hey, would you mind collecting this swab? This is information that we're gaining to help with the rates of cervical cancer in the state of West Virginia.
That's incredible. It's like Cologuard, but for HPV-related cancer. And I think giving access to people to be able to help themselves is really like one of the things that we can do. But another reason why vaccination needs to be, pushed, and really, we need folks to accept vaccination because this is something that can prevent cancer in your kid. Yes. And I think we would all want that if we could.
Exactly. I got the second my little boy turned 9, I took him for his vaccine. So I'm not advising anything to anyone that I don't advise for me and my family.
And I have a 4-year-old, and I'll be doing the exact same. And, otherwise, to your point, who should get that catch-up vaccine? While my husband and I were in a monogamous relationship for, the past 15 years, I had him get the vaccine when it became available in 2020 for men. He was, 40 years old. I said, you meet the criteria, you're under 45, get it, because I would, if it in theory could help you in any way, I would feel terrible if you hadn't gotten it, and it's 20 years from now and you get it.
And the one thing I can say, and I'm sure you can say the same being a cancer doctor, these HPV cancers are just particularly nasty cancers. I mean, you don't want any cancer, but the suffering and the treatments for this particular, like for cervical cancer, vulvar, vaginal, is so intense and so life-changing that if we can prevent this, it's a huge deal.
I couldn't agree more. And the head and the neck, folks think, I'm coming for a simple tonsillectomy. Well, it's not a simple tonsillectomy. You're getting a radical tonsillectomy. It changes the way that you swallow. You learn to swallow differently. If you end up having to get radiation and chemotherapy, it's radiation and chemotherapy to the head and the neck. And this is the most sensitive part of your body that affects every single minute. It can affect your voice. It can affect your swallowing. It affects making saliva. After you have radiation, you have a dry mouth, you don't taste. So the way you interact with the world changes. I mean, eating is one of life's great pleasures, and the treatment of head and neck cancer really affects those things. And people don't realize how important it is until they lose it. So we want to prevent people from going through this. One thing I do say to my patients, and that is if they have an HPV-related head and neck cancer, they're actually in the lucky camp in the head and neck cancer world, because the survival rate for our HPV-related cancers, if caught early, is 90 to 95%, assuming they go through the prescribed treatment plan based on National Cancer Center Network guidelines. But I think the problem is some folks present later, and sometimes it's just getting the awareness out there of what's the first symptom so they can be caught early, right?
So we're talking about first symptoms. First symptoms for cervical cancer, vulvar cancer, vaginal cancers, my cancers that go along down below, is going to be abnormal bleeding, especially bleeding after sex, bleeding in times when you're not on your period. Honestly, a lot of gynecologic cancers present that way. So any woman or anyone with female parts who is having abnormal bleeding outside of their normal menses cycle should go in just to get checked, just to make sure. And even if there's nothing going on, hey, get your pap test, get your other things done, and hopefully prevent something like this from happening to you.
Just your yearly exam.
Yes.
I mean, none of us like that exam.
No.
Nobody likes that exam, but it's so worth it to catch a cancer maybe early.
Exactly. Especially in West Virginia. So the cervical cancer rate, so whenever we talk about cancer rates, we a lot of times talk about in 1 per 100,000 people throughout the United States.
Mm-hmm.
In the United States, it's about 8 per 100,000 people get cervical cancer. But in West Virginia, it's about 10 per 100,000 people. Wow. So that's 2 more per 100,000 people in the United States, in the West Virginia, that are getting it than in West Virginia. And not only does it have to go along with your HPV exposure, your lack of, the fact that it's a little bit harder to get screening, or maybe we're not getting the screening that we should because of education or because of access. There's also other factors that make the HPV virus act up a little bit and become a little bit more malignant. Unfortunately, here in West Virginia, we are a state that smoking is very prevalent, and HPV loves cigarette smoke.
Yeah, and we have that same problem here. Earlier you were talking about, what percentage of cervical cancers actually are due to the human papillomavirus. Well, for head and neck cancer, it's about 70%. The other 30% of oropharynx cancers are caused by smoking. And unfortunately, those patients who are both smokers and have an HPV-related cancer do worse than those who are never smokers and have an HPV-related cancer. There tends to be more mutational burden in their cancer and more, therefore, radiation resistance and treatment resistance. So, it's if we could cut down on smoking, that's the other thing. We're number 1 in smoking in the United States. And so we can also, unfortunately, extrapolate and say we probably have worse outcomes because our patients are smokers.
And we do. And in addition to primary smoking yourself, I've actually done a study that showed that secondhand smoke exposure increases your chance of getting the abnormal pap smears that is the precursor for cancer. So even if we get the patient to quit smoking, which is fantastic, still having the exposure in the household is still increasing risk. So for the whole health of West Virginia, we got to work on our smoking incidences.
Yeah, it's so interesting. I mean, in the head and the neck, most other cancers are on the decline because smoking is on the decline across the U.S. But HPV is one of the only cancers on the rise, and it's purely because we're behind, in knowing about it and vaccinating for it. But hopefully that's going to change in the next 20, 30 years.
Yeah, I feel like fortunately the story for cervical cancer is actually going in the correct direction, but that has to do with we have screening. We pushed vaccination early. We are finding new ways to screen, such as checking for HPV, where unfortunately in your oropharyngeal cancers, you guys don't have a screening, and you're unfortunately getting a little bit behind in pushing the indications for the vaccine because everything was it was a slower
process. Yeah. And there was, I think, some skepticism at the beginning, really it had to be proven, causality had to be proven, and it had to be proven that it mattered, and it does matter because your prognosis is different. And so we also do HPV, directed HPV testing when the screening test on the cancer, the P16 positivity, is negative, we'll add the HPV testing to make sure we identify those HPV-related cancers, because it helps with patients, I think, in the end. So what is treatment like for your patients? Like which patients should have surgery, which patients should have radiation chemotherapy, which patients may need all of them?
So I would say the majority of patients with cervical cancer are going to get treated with a combination of radiation therapy and chemotherapy. And we give the chemotherapy because it makes the radiation work better. The people who are fortunate we caught this very early may be able to be treated with surgery. So a small proportion of patients may be able to treated with surgery, and the very earliest ones can be treated with non-radical surgery. However, the majority of patients who are going to have a cervical cancer or a vulvar cancer or a vaginal cancer are going to get a radical surgery, or they are going to get chemotherapy and radiation therapy. Depending on the stage, depends on how efficacious the treatment is. Like if it is an early cancer and we treat it with surgery, then you have a very good chance of being cured or not having a recurrence, maybe up to 90%. But whenever we get into the stage 3, and we kind of have we call it, your bimodal distribution, which means you've got 2 peaks. We've got the really early people who we treat and can treat well, but then we've got a big lump that's the stage 3s. And the stage 3s are going to be your chemotherapy and your radiation. And once we hit there, we drop down to about 65% cure rate, which means there's 35% of people that I'm actually doing this very toxic treatment, but does really help. But there's a 35% chance that it's going to come back. And then when we get into the stage 4s, we really drop down to more being unlikely that I'm going to cure. And hopefully, though, I can manage, because we have a lot of new medications and chemotherapies and new immunotherapies that have shown to be effective for treating cancer. So immunotherapy is different from chemotherapy, and it is a marker that's targeted on the tumor that teaches your immune system to fight it. Now, that doesn't mean that it's a completely benign treatment. It can have some pretty crazy side effects, but we have seen some really promising results with these. Yeah.
In the head and the neck, we're only approved to use immunotherapy in the sort of recurrent and metastatic setting. Is that the same in gynecologic cancer?
Correct. Yeah. So you have to have things outside of your cervix or outside of your pelvis, or it has to be recurrent, and then we can give immunotherapy.
Yeah. I think patients see all these commercials on TV and are wondering if this will work for them. But, we have the unfortunate task of saying, well, not yet, not as an upfront treatment. But maybe someday in the future we're going to see more widespread application. So for tonsil cancer, again, it's kind of similar. It's the early cancers that you offer surgery for, those that you can access fully through the mouth, and then we actually add a neck dissection or treatment of all the lymph nodes where that cancer would have spread to. And that typically involves all of the lymph node chain along the jugular vein. So I have a bunch of patients who will come and they say, oh, so you're going to use the robot. This is great. Are you also going to use the robot for the neck dissection? The answer is we usually don't, because we can see a whole lot better and operate on these very, very important structures like the jugular vein, the carotid artery, and all of the nerves in your neck, with lots of exposure and room to do things safely, and not to mention faster. It can be done with a robot through the neck. There's certainly surgeons in the country who have done it in institutions who have done maybe 100, but it's fairly rare. So everything is with the robot and through the mouth. And I get a lot of patients. I don't know, do you get patients that say this, are you the one operating, or is the robot operating?
Yes.
There's a little bit of skepticism out there. I like to reassure patients that the the robot is merely a console that responds and instruments that responds to me.
It's a tool.
It's a tool. And
Yes.
I'm sitting controlling every single movement. And the reason we do it is because the instruments are the size of our pinky fingers and can get into very tiny places like your mouth where my hands can't, even though I have delicate hands,
Yeah.
It's a robot's still better.
And I know you're probably not going to mention it, but I feel I have to bring up that you are one of the world experts in robotic surgery for laryngeal, and have created some procedures and things that we're really proud of here at WVU.
Yeah, you didn't have to say that. That's very kind of you to say. It's robotic surgery is a passion of mine. I think it's a passion of yours, as you're the head of our entire robotic surgery committee for the whole health care system. It's quite an undertaking. We want to offer it, and we want to make these technologies and procedures available to everyone, even if you're in Appalachia and have little access.
It's health equity. The robot maybe not be the correct surgery for you, but we have everything that we can do to treat you with the gold standard best care here at the WVU Cancer Institute, here in Morgantown and throughout West Virginia.
And access to clinical trials.
Yes.
We get the question, do we have any clinical trials for head and neck cancer at WVU? And as yet, we do not. But we are able to get patients into clinical trials if they are interested. We can get you that referral. We are certainly offering the latest based on the most recent clinical trials. We have our radiation oncologist, or the chairman of radiation oncology, Dr. Andy Klump, was on the national trial, the ECOG 3311 trial, treated patients for that trial. And so we have that standard of care being applied to patients who come to WVU for radiation therapy. It's sparing patients added toxicity. It's giving the lowest dose proven to be clinically possible through a major national trial that had 340 some patients in it, over 30 centers participating to get those kind of numbers. And for a surgical trial, that's really quite impressive. We also are going to have in 2 years the results of the Pathos trial.
Oh, wow.
And that is the largest trial ever that has 1,200 patients in it from all over the world. All over Europe and the United States and Canada centers, and Australia, I believe, participating in that trial.
That's a big undertaking.
It's a huge undertaking, and that will tell us really which patients actually need and don't need chemotherapy after surgery. And so we're going to have more information in the next couple of years and hopefully apply that here at WVU.
Yeah, and that's what we do. We take the gold standard, best evidence that we have, and we give you world-class care here close to home.
Yeah. World-class care here close to home. So I think that's going to wrap it up for this episode of Cancer Close Up. Thank you to everyone here at WVU Cancer Institute for having us, and have a great day.